Concepts of surgery. Join our YouTube channel to learn surgery in a simple way. Can you identify the nerve palsy as these cases? Let's find out. Winging of scapula is abnormal movement of scapula during arm motion, due to paralysis of muscles, which help in keeping scapula steady and against chest wall. This is commonly due to nerve injury. We often hear that winging of scapula is a complication of modified radical mastectomy, due to damage to nerve to serratus anterior, also known as long thoracic nerve or nerve of Bell. But there are two more common causes of winging of scapula apart from nerve to serratus anterior. What are these nerves? Let's find out in this video. Scapula is controlled by mainly three muscles. Serratus anterior is supplied by nerve to serratus anterior, also called as long thoracic nerve. Pull of serratus anterior pulls scapula laterally and scapula against chest wall. Trapezius is attached to scapula on medial side and it pulls scapula, especially upper part, medially. Rhomboid muscle is attached to scapula on lower part of medial border and it pulls lower part of scapula medially. Spinal accessory nerve supplying trapezius and dorsal scapular nerve supplying rhomboids. Traverse the neck to reach muscle. Nerve to serratus anterior or long thoracic nerve is present in axilla and lateral chest wall. Spinal accessory nerve and dorsal scapular nerve are at risk of damage during neck dissection, while nerve to serratus anterior is prone to damage in axillary dissection. So there are three muscles acting on scapula to keep it steady and close to chest wall: trapezius, serratus anterior, rhomboids. If serratus anterior gets paralyzed, then due to weakening of lateral pull, scapula gets shifted to medial side because of pull of trapezius and rhomboids. This leads to more prominence of medial border of scapula, so medial shifting of scapula is called medial winging, and it is known complication of modified radical mastectomy. If trapezius gets paralyzed, then due to weakening of medial pull, scapula gets shifted to lateral side because of pull of serratus anterior. However, due to continued action of rhomboids, inferior part of scapula remains in position while upper part tilts laterally, so lateral shifting of scapula is called lateral winging, and it is known complication of neck dissection. If rhomboids gets paralyzed, then there is weakening of medial pull on inferior part of scapula. Due to this, serratus and trapezius pulls inferior part of scapula, making it more prominent. It is known complication of neck dissection. So serratus paralysis shifts scapula medially and medial border gets prominent. Trapezius paralysis tilts superior part of scapula laterally and, in rhomboids, paralysis tilts inferior part of scapula laterally and inferior angle gets prominent. Coming back to the question, in this patient, medial border of right scapula is prominent as compared to opposite side and shifted medially is apparent from decreased distance between spine and medial border of scapula. So this is medial winging and is probably due to paralysis of long thoracic nerve. In this second patient, left scapula is prominent and shifted laterally, but superior part has shifted more, causing tilting of superior part laterally. This is called lateral winging and is due to spinal accessory nerve. In third patient, right scapula has prominent inferior angle than left scapula. This suggests paralysis of dorsal scapular nerve. So to summarize what we have learned about nerve palsy and winging of scapula, medial winging is due to long thoracic nerve palsy, supplying serratus anterior muscle. Lateral winging is due to spinal accessory nerve palsy, supplying trapezius. Palsy of dorsal scapular nerve supplying rhomboids also causes lateral winging, but with more prominent inferior angle. Concepts of surgery. Join our YouTube channel to learn surgery in a simple way.